Welcome to The Explainer. Today, we're stepping right into a real-life medical mystery alongside a team of doctors. It all kicks off the second a baby is born, and right away, the air is filled not just with cries, but with some really puzzling questions. So I want you to picture a delivery room. A baby has just arrived, but the medical team's focus isn't just on that first cry. Nope. They're looking at a whole series of physical clues that, honestly, don't seem to add up. These are the very first pieces of a super complex puzzle. Our case file opens with a bunch of clues, and what's interesting is that a lot of them were on the radar long before the baby was even born. They were already painting a picture of a really complex journey ahead. Okay, so this was a pregnancy that came about through IVF, and during routine ultrasounds, doctors started to flag some concerns. They suspected something called an omphalocele. That's a condition where some of the baby's abdominal organs are actually outside the body. They also saw that some bones, the femur and humerus, were small and kind of curved. There were cysts on both adrenal glands and way too much amniotic fluid. Any one of these is a concern, but all of them together, that points to something bigger, something systemic. Then, at birth, the physical exam just adds more pieces to this puzzle. The baby has an unusually large tongue, that's called macroglossia, a fissure in the soft palate, and these very distinctively folded ears. Even the umbilical cord was noticeably large. Now, when doctors see this many different, seemingly unrelated issues all at once, they know they're probably dealing with a syndrome, a single underlying cause for all these different effects. So, you've got this list of clues that just don't seem connected. How did doctors possibly turn that chaos into clarity? Well, they don't guess. They have a system, a kind of playbook for solving these exact kinds of medical mysteries. First off, it's really important to understand what we're even looking for. We're talking about congenital malformations, which are basically errors in the body's fundamental blueprint, its construction plan. They happen in about 2 to 3% of all newborns, and they can be caused by a whole range of things, from genetics to environmental factors. And this part is crucial. Not all defects are created equal. As this slide shows, doctors classify them based on where they came from. Is it a malformation, like an error baked right into the genetic blueprint, or maybe a disruption, where something from the outside damaged tissue that was developing normally? Making this distinction is vital because it helps narrow down the search for the root cause. It tells them if they should be hunting for a genetic problem or an environmental one. So, to solve this puzzle, doctors follow this really clear 4-step playbook. They take a detailed history, they do that meticulous physical exam we saw earlier, they run extra tests like imaging and blood work, and then, finally, they use all of that info to guide a genetic study. It's a true process of systematic investigation. Okay, let's get back to our case and see this process in action. The team has the history and the physical exam done. Next up, the complementary tests, which are going to help them narrow down that list of suspects. The lab work comes back and it reveals a life-threatening clue. The baby's blood sugar was dangerously low, just 20 milligrams per deciliter, and it wouldn't stabilize. For a newborn's brain, which is developing so fast, this is a full-blown emergency. It requires an immediate IV of glucose. Imaging then confirmed those adrenal cysts and also found a widening of the coronary arteries. But that persistent low blood sugar, that in particular, is a huge, huge clue. So let's put it all together now. The large tongue, the issues with the umbilical cord, the organ cysts, and especially that persistent low blood sugar. What's the most likely diagnosis here? All of this evidence points very, very strongly to one prime suspect. And that prime suspect is Beckwith-Wiedemann Syndrome, or BWS. The collection of symptoms we have fits the clinical picture for this condition almost perfectly. It's a really strong match. Now, this isn't exactly a common condition. BWS is a rare genetic overgrowth disorder, and it's estimated to affect about 1 in every 10,000 newborns, though, to be fair, it's probably underdiagnosed in milder cases. So, at its core, BWS is caused by a genetic imbalance on one specific part of chromosome 11. The simplest way to think about it is this. Genes that act like a gas pedal for growth, like one called IGF2, are turned way up. At the same time, genes that act like a brake, like CDKN1C, are turned way down. The result of all that? Uncontrolled cellular overgrowth. And this is a brilliant illustration of how doctors formalize their suspicion. They use a scoring system. So cardinal or major features, like the macroglossia our patient has, are worth 2 points. Then suggestive features, like the hypoglycemia, are worth 1 point. Our patient easily scores 4 or more, and that's actually enough to make a clinical diagnosis, even before you get any genetic confirmation. So the really crucial point here is that getting this diagnosis is about so much more than just putting a name to the condition. It has huge implications for the child's future, because BWS carries a significantly higher risk of developing certain childhood cancers. That means this child needs a strict surveillance protocol with regular screenings for years. So the clinical diagnosis seemed totally solid. The puzzle pieces fit, the scoring system confirmed it, it looked like case closed. But just when the mystery seemed solved, the case took a completely unexpected turn. The targeted genetic test, the one designed specifically to find the exact molecular error that causes BWS, came back negative. No alterations found. Nothing. This was a direct contradiction to all of that powerful clinical evidence that was pointing straight at the syndrome.
As the baby's journey continued, other medical issues came up, including the need for intestinal surgery. But it was during a routine eye exam that another piece of the puzzle appeared. They found atrophied arteries in the back of the eye and abnormally small eyeballs. This wasn't just another symptom. It was a symptom that actively contradicted the leading diagnosis. It just doesn't fit the profile for Beckwith-Wiedemann Syndrome at all.
So this new contradictory finding, combined with that negative genetic test, forced the medical team to just stop and reconsider everything. And it's right here that we find the most important lesson of this entire case. Now, it's true that up to 20% of BWS cases can have a negative genetic test. Sometimes that's because of something called mosaicism, where the genetic error is only in some cells but not others. But that new inconsistent eye finding, that changes the game. It means the team can no longer be certain. The mystery is not solved and the case remains open. And this leaves us with the really profound takeaway from this whole complex case. In medicine, having a strong initial suspicion is absolutely crucial, but it can also be a trap. The true art of diagnosis is being able to hold that suspicion lightly, to constantly reevaluate as new data comes in, and to never, ever stop exploring all the possibilities. Because sometimes that first answer, well, it isn't the final one.